Today, our topic for the webinar is going to be management of comorbidities in type 2 diabetes patients. And our speaker is Dr. Francisco Pasquel. He is assistant professor of medicine at Emory University. He completed his training in internal medicine and endocrinology at Emory University School of Medicine and received his master in public health degree in epidemiology from the Rolling School of Public Health. So he works with us here at Grady Hospital. So he's going to talk with you more about management of comorbidities in type 2 diabetes. If you have any questions at the end of the presentation, please do it in the Q&A tab. After the webinar, I'm going to send a thank you email with a survey monkey that you have to complete to receive the CEU credits. So thank you again, Dr. Pasquel, for the webinar. So now we're going to talk about that.
Hi, good afternoon, everybody. Move this a little bit. Okay, perfect. You see we have 20 participants. I think towards the end we'll have a few minutes to answer a few questions if you have any. But the topic today is management of comorbidities in patients with diabetes. And let me see, trying to move my course. Perfect. So here are some disclosures. I have received honorarium from some of the companies. I talk about some medications during this lecture. It's my obligation to present this to you. When we talk about comorbidities, essentially what we're talking about at this lecture is mainly about the main comorbidities associated to diabetes in patients, particularly patients with type 2 diabetes, which is cardiovascular disease. And when we talk about cardiovascular disease in patients with diabetes, we usually refer to atherosclerotic cardiovascular disease, so ASCVD. And when we're talking about ASCVD, we're referring to the coronary disease, we're referring to the risk of strokes, we're referring to arterial disease in the lower extremities. Essentially, we're talking about atherosclerosis occurring at multiple levels that can be related to this rupture of the atherosclerotic plaque that leads to this thrombotic event that causes the ischemia and infarct of these different tissues and organs. So when we're talking about cardiovascular disease, we're basically referring to this type of cardiovascular disease in patients with diabetes, with atherosclerosis and heart failure as the main ones in this population. This slide, for example, shows the risk of cardiovascular events in patients with diabetes compared to patients without diabetes. For example, we see that coronary heart disease is much more frequent compared to non-diabetic patients. This is the hazard ratio is of 2, meaning that patients with diabetes have twice the risk of coronary disease. Same for stroke, and particularly we're talking about ischemic stroke that is related to atherosclerosis. Also for hemorrhagic stroke, is mostly related to hypertension. And other vascular deaths are all these different outcomes are higher in patients with diabetes compared to non-diabetic patients. But it also matters how patients with diabetes are treated in the evolution of their disease. So just by having a history of diabetes doesn't mean that the risk is extremely high compared to patients without diabetes. What it matters is the length or the evolution of diabetes and the type of diabetes that patients may have. And I think this this figure illustrates this idea. This is data from a large cohort that included patients without diabetes and with diabetes. And in this figure, you can see different categories here. These different lines represent different categories of patients with different risk at baseline. And in this study, what they did is classify patients with diabetes as having severe or diabetes only. And severe was defined as the use of insulin or microalbuminuria, the presence of microalbuminuria, which are typical markers of advanced diabetic disease. So in this figure, you can see the cumulative incidence of coronary heart disease events here on the y-axis, and here over time you can see that the participants in this cohort with the lowest risk here in blue are those without a history of diabetes and without a history of coronary disease. If we just add diabetes as part of the history, we can see that over time that risk starts increasing a little bit. However, when we compare people with a history of coronary heart disease, so people without diabetes that had a cardiovascular event, compared only to diabetic patients that have severe disease, meaning that they are using insulin or have had advanced disease with microalbuminuria, we can see that they're quite equivalent. Patients with diabetes, severe diabetes, are equivalent to people that had a coronary event before. But what is clear from this figure is that those patients with the highest risk of all are those patients that have diabetes and have a history of coronary disease. So patients with diabetes that already had an infarct, already had a stroke, those are the highest risk patients. And we're going to talk a little bit more about those patients when we talk about cardiovascular outcome trials using different kinds of medications. It is clear that the incidence of events is declining in patients with diabetes when we adjust for age and for the population, meaning that we're treating patients better. Patients are having less events. On the right side, we can see that the standardized rates of death related to cardiovascular disease in patients with diabetes have been declining over time. However, when we look at the absolute number of people, as people is aging, the global population is still growing. Obviously, the number of people with events continues to increase at the population level. This slide shows that we have improved the way we manage our patients with diabetes, and the incidence of strokes and heart attacks are going down. The same for microvascular complications, even for hyperglycemic crisis. We have had some improvement over time. There's a recent data also analyzed by the group of Edward Gregg from the CDC that actually shows that maybe this is starting to go up in the last few years, and we don't understand that very well, but maybe related to the increase in the incidence of diabetes in younger populations. So for this lecture particularly, when we're talking about these comorbidities that go along with diabetes, we're basically talking about those metabolic changes, those risk factors that go along with diabetes commonly. It is really strange. It's rare to find patients with diabetes alone. That actually represents a minority of the population. Maybe just 1 out of 10 only has diabetes in our clinics. We actually see that most of our patients will either have a combination of diabetes with hypertension and dyslipidemia, or diabetes and hypertension, or a combination of diabetes with dyslipidemia. So we're going to talk about those because those are very important risk factors when we talk about cardiovascular risk in patients with diabetes. So when we're talking about cardiovascular disease, we can talk about hyperglycemia and insulin resistance and its relation to atherosclerosis. We know that higher levels of glucose are associated with increased risk of infarct and stroke. We know very well that higher cholesterol is associated with atherosclerosis. We know that hypertension is associated with atherosclerosis, or that increased coagulability is associated with atherosclerosis and infarcts. And all those conditions are common in patients with diabetes. This cartoon here just illustrates what's going on in those arteries that we were mentioning at different levels. And basically what this slide is showing is here this plaque that is almost occluding the vessel. That is rich in lipids. In this case, it ruptured and brought all these platelets and factors that cause coagulation and cause an infarct. And essentially what we typically see is that in this cartoon on the right part is that in the underlying part, under the endothelium, there's this accumulation of inflammatory cells that are becoming these foam cells that are increasing this inflammatory process in the coronary vessels, in the central nervous systems, lower extremity, etc., which are the places where atherosclerosis is occurring. So let's discuss a little bit more about hyperglycemia in atherosclerosis and what we have tried to do in the last years to try to improve outcomes in patients with type 2 diabetes. So we know that cardiovascular disease may be related to glucose. So there have been several studies that tried to improve glycemic control to see if we could prevent mortality in patients with diabetes. So with previous medications, there were large attempts to try to prove that we can decrease A1C to lower levels, 6.5 or 6, and see if we could prevent cardiovascular outcomes. However, when they conducted those large trials, the Accord trial, the Advance trial in Europe, and the study from the VA-DT trial, we learned that actually when we tried to decrease cardiovascular events, lowering A1C levels with those strategies actually didn't work. And in the Accord trial, it actually was associated with increased mortality. Since then, the strategies to manage diabetes changed. We were afraid of being too aggressive on lowering A1C around that time. And since then, we typically have this approach, which is metformin. We know from older trials from the UK PDS that the use of metformin may be associated with a better cardiovascular profile. And after metformin, we used to say that we could add any of the following medications. In terms of the next medication that comes after diabetes, there were recommendations to either use sulfonylureas, TCDs, DPP4, the newer medications, SGLT2 inhibitors, GLP-1 receptor analogs, or insulin. And all choices were considered acceptable. But we'll talk about some of the newer medications and maybe in newer trials that made that actually led to changes in the way we manage hyperglycemia in patients with diabetes. And those outcome studies are large clinical trials that studied these newer medications for the management of diabetes in patients at the very high cardiovascular risk. Remember, I mentioned those patients with diabetes and the previous cardiovascular events are the highest risk patients. And the FDA mandated that all these new medications have to prove that they are safe in this population. And what we actually learned from these clinical trials is that these newer medications, both SGLT2 inhibitors such as empagliflozin or CANagliflozin, or GLP-1 receptor analogs like liraglutide, semaglutide, or dulaglutide, actually have shown a reduction in cardiovascular events in patients at the highest risk. The LEADER trial, for example, with liraglutide, this is a GLP-1 receptor analog injection that is injected once a day. And GLP-1 receptor analogs are basically molecules that mimic what the incretin system does, which is a hormone that comes from the gut, goes to the beta cell of the pancreas, increases insulin in response to glucose, decreases glucagon levels, so decreasing the amount of glucose production. It also has receptors in the central nervous system, so decreasing satiety. These medications are associated with weight loss. So this trial, this was the first large clinical trial that showed actually a reduction in cardiovascular outcomes in patients with type 2 diabetes with very high cardiovascular risk. And the primary outcome for all these clinical trials that have to prove that they are safe in patients with diabetes is the typical combination of mortality, death related to cardiovascular causes, non-fatal MI, and non-fatal stroke. So this MACE outcome is a typical combination of those three types of events. And in this slide, you can see on the left that actually this study was superior, not just not inferior. It was actually superior to placebo in reducing cardiovascular events in patients with high cardiovascular risk. And this study was also associated with a reduction from death from cardiovascular causes. Similarly, a more recent study with semaglutide showed a similar reduction in the primary outcome, which included the same types of events: non-fatal MI, non-fatal stroke, and cardiovascular death. Significant reduction with exposure to semaglutide compared to placebo in patients with high cardiovascular risk. Studies with SGLT2 inhibitors have shown similar outcomes. CANagliflozin and empagliflozin, dapagliflozin, those are medications that work in the kidney at the proximal tubule level, where they block the transporters for sodium and glucose. These medications work by increasing glycosuria, so there's osmotic diuresis that occurs with increase of glucose in the urine. And glucose levels come down and patients lose calories. This medication is also associated with weight loss. It significantly decreases A1C. And when they conducted these large clinical trials, they actually observed that patients with high cardiovascular risk randomized to CANagliflozin or empagliflozin have actually a reduction in cardiovascular events, as showed in this slide, with exposure to CANagliflozin versus placebo. The hazard ratio is 0.86, meaning a 14% reduction in this primary outcome. More recently, a study with CANagliflozin also showed that in patients with high cardiovascular risk, but also with significant diabetic nephropathy, the use of these medications are actually reducing cardiovascular outcomes and reducing renal outcomes. In this recently published study with CANagliflozin, they enrolled patients that were older than 30 years with type 2 diabetes and A1C between 6.5 and 12. They all had CKD with a GFR between 30 and 90, and at least 60% of this population had a GFR between 30 and 60. And all of them had significant albuminuria, meaning an albumin-creatinine ratio more than 300 milligrams per gram. And the primary outcome for this study was the combination of doubling in serum creatinine, end-stage renal disease, renal death, or cardiovascular death. And here on the upper left of this figure, we can see that there was a significant reduction in this primary composite outcome when they looked at a specific renal outcomes or end-stage renal disease, or a combination of dialysis, kidney transplantation, and renal disease. There was a significant reduction in all these outcomes in patients that were treated with this medication compared to patients treated with placebo. So here, this is expanding the benefit of SGLT2 inhibitors in this population. What has been seen differently between GLP-1 receptor analogs and SGLT2 inhibitors is that SGLT2 inhibitors, maybe because of that mechanism of osmotic diuresis, actually work the best in patients with a history of heart failure. And the reduction in hospitalizations for heart failure in patients treated with SGLT2 inhibitors is actually quite impressive. So in a way that cardiologists are actually conducting several trials in patients without diabetes, treating them with these medications to improve outcomes. And results for those large clinical trials are pending. In this study, also, they showed a reduction in cardiovascular death, MI, or stroke. So again, reproducing these findings that were shown with the previous clinical trial. And as we mentioned, GLP-1 receptor analogs consistently have shown a reduction in cardiovascular events in large clinical trials. I just wanted to show you one of the newer agents that are coming out that might be coming out to the market in the next couple of years. Is this new group of agents that actually work through GIP mechanism and GIP receptors. So GIP is the other incretin that is also produced in the intestine in response to nutrients. And this medication particularly is GIP. it was modified so that it also can activate GLP-1 receptors. This has a quite impressive reduction in hemoglobin A1C, in weight. Almost 90% of patients treated in phase 3 trials achieved an A1C less than 7. So large cardiovascular trials with these medications are actually undergoing and are under design, and we'll see the results in the next few years. So this is the typical algorithm that we had for the management of diabetes in patients with type 2 diabetes. And essentially we had metformin as the initial medication of choice, and then we had all these other options. But based on the recent clinical trials, we actually have modified the way we treat our patients with diabetes. This slide is showing actually the new guidelines that were written in collaboration between the American Diabetes Association and the European Association for the Management of Diabetes. And they essentially stratified patients according to their underlying characteristics. If a patient has cardiovascular disease, either atherosclerotic cardiovascular disease or CKD, patients should be treated with SGLT2 inhibitors or GLP-1 receptor analogs. And this is after metformin. Metformin is still the first-line agent. So the next question is, does the patient have cardiovascular disease or kidney disease, diabetic kidney disease? Then if there's a predominance of atherosclerotic cardiovascular disease, then maybe a GLP-1 receptor analog is the best agents, because these agents have shown a reduction, some of them, a reduction in stroke, for example. However, if we have a predominance of heart failure, a patient really should be treated with an SGLT2 inhibitors. These medications have shown unprecedented results in those patients. There's no medication that has that effect in patients with heart failure and then diabetes. So a patient with heart failure and diabetes should be treated with an SGLT2 inhibitor, particularly if they have heart failure with reduced ejection fraction. And if a patient has CKD with significant albuminuria, then also an SGLT2 inhibitor might be a great medication for them. There has been reports of also improvement in outcomes with GLP-1 receptor analogs. So therefore, the guidelines have changed in the sense that we're considering these factors when we're deciding about the way we treat hyperglycemia in patients with diabetes. So that is the new change in the way we manage diabetes when we think about hyperglycemia in patients with high cardiovascular risk. And this is just a magnification of the previous slide showing that different strategy for high cardiovascular risk patients. So let's move to hypertension. Hypertension is very common in patients with diabetes. The incidence goes up in patients both with type 2 and type 1 diabetes according to age. At the time of diagnosis in patients with type 2 diabetes, almost half of them have hypertension, and the incidence and the prevalence of hypertension is quite high in later years. And we know that systolic blood pressure, mean systolic blood pressure, is shown here, is the higher it goes, the higher it is associated with both microvascular complications and macrovascular complications in patients with diabetes. This is data from the United Kingdom Prospective Diabetes Study, with one of the major diabetes studies that we have. And it clearly shows that there's a linear relationship between higher blood pressure levels and cardiovascular, microvascular, and macrovascular outcomes. What we learned from the UK PDS study is that controlling blood pressure, it's actually associated with a significant reduction in stroke, a significant reduction in microvascular disease, and a significant reduction in heart failure. In this figure, you can see that those patients randomized to the tight blood pressure arm had a significant reduction, a 44% reduction in stroke, 37% reduction in microvascular disease, and 56% reduction in heart failure, therefore showing the importance of controlling blood pressure in patients with diabetes. And the goals of therapy have changed over time. Initial goals came down to 140/90, and then further down to 130/80 for certain groups of patients. And in current recommendations have been to treat blood pressure to less than 140/90. In more recent recommendations, 130/80 for most patients with diabetes. What is important when we manage blood pressure in patients with diabetes is that we don't need to only use medications. There's actually several non-pharmacologic measures that we can implement to decrease blood pressure. So significant weight reduction, for example, is associated with 5 to 20 millimeters of mercury of systolic blood pressure. And that can be clearly seen, for example, in studies where patients undergo gastric bypass, that many of those patients actually stop taking blood pressure medications. Changes in diet can improve blood pressure, dietary consumption of sodium, physical activity, and maybe a moderation in alcohol consumption. This is not generally recommended, but this is just to show the different ways that we can modify blood pressure. The medications that we typically had for the management of diabetes have always been ACE inhibitors and blockers of the renin-angiotensin system, blockers of AT2 receptors. And this group of medications, renin-angiotensin system blockers, are excellent medications in patients that have micro or macroalbuminuria. Those are the medications of choice, and they might also have an effect in reducing the progression of retinopathy, and they may also have some effect in improving insulin sensitivity. The data is not very strong in that aspect, but the effect in patients with albuminuria is quite significant and important. Some of the potential side effects that we have these medications with ACE inhibitors is dry cough, for example. We have to consider potassium levels, because these medications may increase potassium, so we need to monitor potassium and kidney function. And they may also, in rare occasions, be associated with angioedema. So one of the recent questions has been, are renin-angiotensin system blockers the first line agents for all patients with diabetes? And recent systematic reviews and meta-analysis have shown that actually the other medications that we use for the management of blood pressure in patients with diabetes, such as calcium channel blockers or diuretics or beta blockers, actually work perfectly fine in this population. And there's no significant difference in a hard outcome such as death when patients are treated with calcium channel blockers versus renin-angiotensin system blockers or diuretics or beta blockers compared to those agents. So since then, guidelines have actually changed, and currently the recommendation is to treat patients with diabetes with any of those agents. However, if a patient has a history of albuminuria, then they definitely need to be treated with one of those agents, either ACE inhibitors or ARBs. The current recommendations for the management of blood pressure in patients with type 2 diabetes is that if blood pressure levels are higher than 160s or 100s, in addition to lifestyle therapy, we probably need to start already with 2 medications, either a single pill combination or 2 new drugs for those patients to reduce cardiovascular events in this high-risk population. So we need to be a little bit more aggressive, particularly for those patients with very high blood pressure levels. And we obviously need to implement lifestyle interventions such as weight loss, DASH style diet, increased physical activity. And those agents that we use for the management of hypertension can either be an ACE inhibitor, ARB, a thiazide-like diuretic, or a calcium channel blocker. And in general, most patients end up needing more than one agent. So multiple drug therapy is generally required to achieve blood pressure targets. When we're using these agents, these renin-angiotensin system blockers, it is important that we monitor creatinine levels. And we have to use these agents, particularly in patients with significant albumin to creatinine ratio elevation, such as those with levels of more than 300 per milligram per gram of creatinine. So the recommendations for the management of diabetes, trying to simplify this in this algorithm, The recommendations will be to, for example, for those patients here in this algorithm on the left side, if the initial blood pressure is less than 160 over 100, we can start with one agent in lifestyle management. And then we ask the next question: does the patient have albuminuria? If the patient does not have albuminuria, then we can either treat with a renin-angiotensin system blocker, a calcium channel blocker, or a thiazide diuretic. However, if the patient has albuminuria, patients should be treated with a renin-angiotensin system blocker. On the right side, if we have a patient with initial blood pressure more than 160 over 100, then we should start with two agents, and the similar approach applies. We ask if the patient has albuminuria or not, and we decide on those medications according to the presence of albuminuria. And obviously, if the patient does not meet target, we combine therapy, we continue to assess, and then at the end, we need to, if we have to, we can add other agents such as mineralocorticoid receptor antagonist. And it's always important to consider that if we're combining these agents with renin-angiotensin system blockers, we need to monitor potassium levels closely because of the increased risk of hyperkalemia. Let's move now to dyslipidemia in patients with type 2 diabetes. We know that hyperlipidemia is closely associated in the pathophysiology of coronary heart disease and atherosclerosis in general. We know that LDL, for example, in this cartoon is showing that LDL comes inside the adventitia, the intimate adventitia, and there's retention of this LDL that is modified. There's an uptake of this oxidated LDL, but this macrophages, and there's accumulation of this inflammatory cells here in the vessel, and that increases atherosclerosis, and then inflammation makes this plaque more likely to rupture. And when that happens, that's when the atherosclerotic event occurs. Patients with dyslipidemia sometimes can be identified by some physical signs. Here, for example, a patient with arcus cornea, showing that a patient has likely significant hypercholesterolemia or the presence of xanthelasma. Fortunately, now lipid panel measurements are quite routinely measured, and they should be measured in all patients with diabetes, so we can identify those patients at the highest risk from the beginning of the management, of the comprehensive management of diabetes. To manage dyslipidemia, we can always target LDL first. We know that lowering LDL is associated with a reduction in cardiovascular events. There's approaches to raise HDL and lower triglycerides. However, the clinical trial data is not very strong for the other approaches to manage dyslipidemia. But for example, we know for sure that exercise can modify triglycerides and HDL, and it's positive and decreases cardiovascular risk. So that's one of the strategies for those patients that have this significant type of dyslipidemia. And we know that glycemic control will also modify triglycerides and HDL. There's large studies conducting, investigating the use of fibrates, for example, to lower high triglyceride levels in patients with diabetes, to see if we can reduce cardiovascular events in patients with this typical dyslipidemia of diabetes. Data from postdoc analysis of clinical trials with fibrates suggest that lowering triglycerides is associated with a reduction of cardiovascular events. When we talk about dyslipidemia management, we essentially talk about statins for all our patients with diabetes. We know that the statins such as rosuvastatin and atorvastatin are high-intensity statins, and they actually can reduce up to almost 60% LDL cholesterol levels. And at the same time, they have this added benefit of decreasing triglyceride levels and raising HDL. We have other statins such as Simva and pravastatin that may reduce between 20 and 60% LDL levels and other less potent statins such as fluvastatin. This table is just showing the potential effect according to different doses of this different commonly used statins. But here on the left, basically showing the most potent statins that are now generic and can actually significantly modify the risk cardiovascular disease risk in patients with diabetes. These are high-intensity statins, and we use them very commonly in this population because they also can increase HDL levels, decrease triglycerides. However, if a patient has been treated with these older agents and it's working, it's absolutely, we can continue. Several trials with simvastatin in patients with diabetes have shown a reduction in cardiovascular events when we lower LDL cholesterol. Some of the side effects associated with statin use are muscle injury, muscle pain. So if this occurs, we typically change the statins to different kinds of statins. If patients are really not even able to tolerate very low dose of statins, such as, for example, 5 milligrams of rosuvastatin, or 5 milligrams every other day of something like rosuvastatin, or lower doses of atorvastatin, we can think about other agents. We can use something like ezetimibe. It's a medication that decreases the absorption of cholesterol in the gut, or bile acid sequestrant such as colesevelam, which actually has some reduction in A1C effects. We may consider fibrates for patients with very high triglyceride levels, particularly for those that have levels above 500 because of the risk of pancreatitis. The data with niacin is not strong. One of the recent questions in the last years has been, is lower LDL better? Or is it just a pleiotropic effect of statins beyond lowering LDL cholesterol? What we have learned is actually that when we treat with non-statin medications that can also decrease LDL, we actually see a further reduction in very high-risk people. In the IMPROVE-IT trial that randomized patients to simvastatin and ezetimibe versus simvastatin monotherapy, they saw a reduction in cardiovascular events in a very high-risk population. In this population, there was a very high risk of events. As you can see, over a few years of follow-up, more than 30–40% of patients had cardiovascular events. And when they analyzed this data according to diabetes status, they actually showed that patients with diabetes are the ones that actually benefit the most from a further lowering in LDL. And the actual number needed to treat in that study was around 25 patients to reduce one event. Therefore, for patients at the highest risk that had a recent cardiovascular event, have diabetes, and are well controlled with a statin, and we actually need to further reduce that LDL in patients with acute coronary syndrome and LDL levels over 50, we can consider combining a statin with ezetimibe, for example, to further reduce cardiovascular risk. But this table is showing our general approach for the management of dyslipidemia in patients with diabetes. And essentially what you can take home from this table is that if a patient is younger than 40, we only treat them with statins if they have high cardiovascular risk. If they have a history of ASCVD, we obviously need to treat them. If they have risk factors, which is a large population of patients, we need to consider a statin in that population. But when we're older than 40, everybody needs a statin. So in general, for all patients with diabetes older than 40, a statin use is recommended, and the higher intensity statins for those at the highest cardiovascular risk. So in general, the new recommendations is that, for example, we can combine statins with other agents that further reduce LDL for those patients at the highest risk, for example, patients that had a recent cardiovascular event. Other way to reduce LDL is the use of monoclonal antibodies that inhibit PCSK9. Those inhibitors, such as evolocumab, have shown that a significant reduction further beyond the effect of statins is actually associated with reduced events. So when we use agents like PCSK9 inhibitors, it has consistently shown that a further reduction of LDL is associated with a lower incidence in cardiovascular events. So again, showing that it's not just the use of statins, it's actually lower cholesterol levels that is associated with a further reduction in cardiovascular risk in patients with diabetes. Finally, let's move to the use of agents that can decrease platelet aggregation in patients with diabetes, because patients with diabetes have higher levels of molecules that increase thrombogenesis. So patients with diabetes tend to have a higher tendency to form clots and are at the higher risk of having cardiovascular events because of this reason. Uh, the current recommendation for aspirin is to use aspirin in those at the highest risk of cardiovascular events, and in general in primary prevention, which means a patient has not had a cardiovascular event before. We should consider the use of aspirin for those that are at the highest risk, which are patients older than 50 years that have significant cardiovascular risk factors. A way to stratify patients is to actually use the tools that we have available from the American Heart Association, Framingham risk scores, etc. So which actually tell us the risk of a patient of having a cardiovascular event in the next 10 years. So if a patient has a risk that is higher than 10% based on those estimations, then a patient should probably be on aspirin therapy. The recommendation for secondary prevention is for all patients. So if a patient already had a previous cardiovascular events, then everybody should be on aspirin therapy. The data is much stronger for this population, and the impact of using antiplatelet agents is actually much more important in secondary prevention compared to primary prevention. And for those patients at the highest risk, we can consider dual antiplatelet therapy, such as a combination with clopidogrel with aspirin, for example, for a patient that just recently had an acute coronary syndrome. This slide is basically just showing more recent changes in the recommendations. We used to say for men older than 50 and women older than 60, 65. We actually have changed that recommendations to everybody that it's older than 50 that has an additional risk factors, because we know that women that are postmenopausal have a quite significant increase in their cardiovascular risk. So in general, aspirin is not recommended for prevention of patients with lower risk, because there's an increased risk in bleeding. So for those patients that have low risks, or such as those with a 10-year cardiovascular risk score less than 5%, we usually shouldn't use aspirin. And we should basically reserve this use for those at the highest risk. For those between 5 and 10%, it's at the doctor's discretion. For example, if a patient is a smoker, then maybe we may consider in younger patients. But in general, this is more based on expert opinion. This is a little confirming those data. So finally, after seeing the data, what about the multifactorial approach? So we were talking about managing glucose, management of blood pressure, managing the dyslipidemia, or the use of aspirin. We obviously, when we see our patient in our clinics, we actually conducting a multifactorial approach, and we're actually addressing all of those risk factors, comorbidities at the same time. And one of the studies that actually showed us what we wanted to hear is the Steno trial. This was a smaller study, but it had a long-term follow-up in high-risk patients with type 2 diabetes. And what they did in that study is basically they designed a multifactorial intensive intervention compared to a standard of care. And what they showed at that time is that an intensified multifactorial intervention had a quite significant impact on mortality. And as you can see, when they treated patients with intensive therapy with lower A1C goals, cholesterol goals, lower blood pressure goals, actually patients did much better over time. They showed a 20% absolute risk reduction. If you remember the way we calculate the number needed to treat, we usually divide 100 by that absolute risk difference, and we divide 100 divided by 20. This basically is telling us that we just need to treat 5 patients to decrease one one death when we treat patients with an intensive approach versus conventional therapy. Therefore, guidelines have changed. We tend to address all those risk factors. Now we have strategies to better lower A1C. We have medications that can lower A1C and also reduce cardiovascular risk. We know that statins are effective. We have now those higher potency statins are now generic that we can all use. We have different approaches to manage blood pressure, and we should intensify therapy from the beginning and not wait, especially for those patients at the highest risk. So, in conclusion, A1C, the goal is still to keep it less than 7 for most patients with type 1 and type 2 diabetes. Intensive therapy less than 6 or 6.5 may not reduce cardiovascular risk according to the previous approaches. However, when we use different strategies, such as the use of SGLT2 inhibitors and GLP-1 receptor analogs, the studies have robustly showed that the use of these agents is associated with a significant reduction in cardiovascular risk. And one of the most recent trials with dulaglutide presented at the American Diabetes Association this year actually showed that in a broad group of people, even including patients that didn't have cardiovascular events in the past, and even patients that had lower A1C, the use of GLP-1 receptor analog was associated with a reduction in cardiovascular events. So again, there is solid data that is showing that the way how we treat diabetes and hyperglycemia, it may depend on the type of agents that we use. Therefore, the guidelines have changed to recommend to use this kind of agents in patients at high cardiovascular risk, and we have also seen a benefit in renal outcomes with the use of these newer medications. Blood pressure should be targeted with RAS blockers for those patients with proteinuria, but we know that we can use either thiazide diuretics, calcium channel blockers, and maybe goals less than 130/80 may be indicated for patients at higher cardiovascular risk. But one of the common sense approaches that we should use for our patients is that if it is very easy to use blood pressure agents such as an ACE inhibitor, for example, at a low dose, and we're controlling blood pressure, and blood pressure is at 120/80, there's no reason to decrease the dose and let this blood pressure come up, because it's the burden of side effects associated with lower doses is pretty low. However, when we have patients that are on multiple agents with 3 or 4 medications, or elderly patients that are at high risk of having complications related to the use of these medications, we might not want to be that aggressive with those patients because of the increased risk of side effects. We have also learned that all lower LDL goals are better. Therefore, the guidelines have changed for lower LDL levels for those patients at the highest risk, such as patients with a recent acute coronary syndrome, for example. But in general, the recommendation to use statins is quite broad for everybody that is older than 40 years old, and for those that are younger than 40, to consider history. Obviously, if there's a history of atherosclerotic cardiovascular disease or a significant high risk. And finally, the use of aspirin, it should be especially reserved for those at high cardiovascular risk based on our risk estimation, that risk in the next 10 years of having a cardiovascular event, and absolutely for those patients with a previous history of a cardiovascular event. And I will stop here, and I think we will have time for a few questions if there are any questions from the audience.